Yeah, so today we're going to talk about how we use the helmet device interface when we're using it for non-invasive ventilation. Alright, so for that, what are the equipment we require? So we can use a usual ICU ventilator that you have, like this ICU ventilator. You may also wish to use it using a high flow device. This is attached to the ventilator, but you could use a regular high flow device that you would use in your hospital. The point being, it is good to have humidification. So if you have humidification, it's always better with these kind of devices which have very high fresh gas flows. We could also use the regular flow meter if you have provision to get liters up to 60 to 70 liters along with a blender. So an oxygen air blender, so that you could regulate the FiO2. If you cannot directly use it with the flow meter, because otherwise you would develop 100% oxygen directly. So you may want to use this along with a blender which can mix the air and oxygen and give you a required FiO2. Here at this moment we are not showing you the blender per se, we are not using the blender. We have just kept the ventilator over here and we will show you how to use it with a high flow. It's very different when we are using it with a high flow versus when you are using it with a ventilator. How does the interface look? The interface looks something like this. Okay, the interface has got a release valve over here, which can release the pressure. So the moment you open this, it will release the pressure completely. It opens up completely. At the same time, it releases some amount of pressure if by any chance the pressure goes very, very high. At the same time, it's got this one opening here. It's got a second opening here, which are connections required for the ventilator as well as for the high flow. You've got two more openings right in the front over here. One is to bleed oxygen and the other may be used for even drinking purposes for that matter by inserting a straw over here. Inside also you have this particular connection which is basically filled with air, so that the cushion inside the device inflates and fits snugly around the neck. Now in order to what you see down here are the stirrups or the shoulder straps. So when this goes over the head, it goes under the shoulder. Both these straps go under this shoulder and prevents this from going up as the air fills up. In order to put this into any patient, we require at least two people. Now if you look at the end over here, if you look at the inside, there is elastic over here which needs to be held by two people. So if there are two people holding it, two people have to stretch it out, like how it's stretched out like this. If you look at it, it's stretched out like this, completely stretched out, and then it has to be placed inside the patient's head and then released. So once it's released, it fits snugly around the person's neck. Now this is the difference when you use this versus the mask. In the mask, the entire mask always leaks very often, whereas here this is almost leak proof because it snugly fits around the neck and prevents the escape of air, number one. Number two is the mask is a rigid structure. So if the patient takes a deep breath higher than the peak expiratory, a very high peak expiratory flow, if it takes a very high breath above the flow, then there would be air hunger because it's the fixed amount of air that is over here. Whereas in a helmet, there is a huge amount of compliance and a huge amount of air. So at never given moment, the patient will get air hunger because of the fact that the compliance of the circuit of the entire device is very high. Also, the difference that you would get with this and the mask is the fact that this is absolutely open. So a person can actually see all around and does not feel claustrophobic in any way. Importantly, you must understand that the mask requires very high flows. The mask, when you're using on the ventilator, the flows are upwards of 200 ml, whereas here the flows are somewhere around 60 liters per minute. So there's 200 liters per minute versus 60 liters per minute is the flow difference that you might get when you're using helmet device versus the mask device, because the mask cannot tolerate even slightest of the leak. If there's a leak, it has to increase the force higher and higher, whereas here even the patient breathes heavily, it will still accommodate because of the fact that it's got big compliance and big air. Well, so we also have certain helmets where you have the third attachment also. So this is one of those helmets. If you look at this, it's got one port here, one port here, and another port here. There are three ports that are there over here. Okay, and this is a bust on which we have placed this. It is snugly fitting inside. So let's use this with our regular ventilator. So if I have to use this with our regular ventilator, so I have just taken our regular ventilator. This is the Hamilton C6. It's a regular ventilator that I'm using on the non-invasive mode. You have the non-invasive mode on this ventilator, and on this ventilator, if I'm going to use it with this particular ventilator, I just need one port. I don't need these extra ports. It's not required. These extra ports are really not required. So maybe we can block both these ports by whatever blocker you want. Now here we have used a blocker. We've used one of these devices which is just nothing but just blocking. I can block it even with tape if I want. So I just need to block it. So I'm going to block the port over here. I completely block the port over here. Alright. It's completely blocked. So this air block. There is no more air going or coming in outside from here. There's the same similar blocker that I've used, and I'm putting it over here and completely blocking the port here too. I'm completely blocking the port here too. So now both the ports are blocked. Now this is effectively blocked. Both the ports are effectively blocked, and I have only one port that is open over here. So when I have one port that is open over here, I attach my regular ventilator circuit. My regular ventilator circuit inside this port. The regular ventilator circuit goes inside this. This is what I've done. This is after the helmet has been worn to this particular patient. Now when I come to my settings over here, this is my regular ventilator where I have a non-invasive ventilator that I have keyed in over here. Okay, it's very important that I make you understand the settings that you can keep here. The first setting that you must remember is the PEEP has to be 10 and not less than 10 at any given moment, because that is what keeps the entire helmet to be inflated. If you come down on that, the compliance is such that the helmet does not remain stiff. It starts collapsing a little bit. So in order to improve the stiffness of the helmet and keep it inflated, the PEEP required is 10. Now remember this, the settings of this, the target settings, for example, the pressure support settings or the PEEP settings of this has to be 30 to 50% higher than what you would otherwise set. So if I want to set a pressure support of 10 and a PEEP of 5, then in this ventilator I need to make the PEEP of 10 and the pressure support of 15. So it's 30 to 50% higher than what you would have done with a normal NIV, because of the fact that this got a huge amount of space that it needs to cover. So I'll just repeat that once more. If I want to give a pressure support of 20 for that matter, I would need to give at least 28 to 30. If I want to give a PEEP of 10, I would need to give at least 14 to 15. Okay, if this is what I want to do. However, I will never come less than 10 of PEEP, because if I come less than 10 of PEEP, there'll be a problem in that. All right. Another thing that I want to emphasize on this is that whenever I am setting this patient on this ventilator, the tidal volumes that I must achieve has to be 1000 to 1500. This is the amount of tidal volume that I should see on my monitoring facility. 1000 to 1500 tidal volume, expiratory tidal volume. And when I'm putting this patient on, and also the minute ventilation has to be 25 liters per minute, at least. Why is the minute ventilation need to be 25 liters per minute? Because it needs to wash out the carbon dioxide. So let's set this patient on this particular ventilator. So if I have this patient, I'm going to start. I have blocked both the ports and I've attached the ventilator to this. And I'm going to start my ventilation at a PEEP of 10 and a delta PEEP of 5, which means 15. So it's PEEP of 10, that's the minimum PEEP I need to keep. And a delta PEEP of 5 means a total pressure support of 15. So now let me see when I start ventilation what really happens. Can somebody hold this please? So we have not put the stirrup, so I'm hoping that, so this is how it inflates. And once it's inflated, it's inflating. Okay. The stirrups will not allow it to go up per se. Of course, we have not put the stirrup, so it's kind of going up over here. But if you come here, you can see what's happening here. So you have the minute ventilation to go up to more than 25 we require, and the tidal volume is already more than thousands. So we have minute ventilation of 25, and we have tidal volume going up to more than 1000 is what I want. So if it's not going above 1000, I would increase the pressure support here. So if I increase the pressure support here to 6 maybe, I'll see whether this goes up further, and it will go up further. It's 1248. So we have now adequate ventilation occurring and adequate oxygenation occurring, that is with respect to the NIV per se. More than 1000 tidal volumes and minute ventilation more than 25 liters per minute. Now how do I know that the patient is ventilating quite well? I can do something very simple. I can just put my mainstream capnograph inside. Have you seen what I've done? I've just put my mainstream capnograph inside. That's my capnography that's there lying inside. Just a mainstream capnography just lying there inside. If I find my capnography showing more than, if I find this going more than 5 millimeters of mercury that we normally see in EtCO2 is going more than 5, then I know that there is CO2 retention happening and I need to do further things. Now, if there is CO2 retention happening, if that has gone more than 5, okay, it's 10 or 15, I need to remove more fresh gas. So what do I do in this case? I can also add a oxygen from here. I can just add oxygen from here into this pot, and I can run it at 8 or 10 liters per minute, which will actually flush out the oxygen flush out the carbon dioxide that is remaining inside. So I can actually attach an oxygen over here. Whereas this port actually is used for actually feeding the patient also. For example, if I want to feed the patient, it's best to actually give these patient liquids. How do you do that? You open this up from here, okay, and then let's assume this is a straw. Let the straw go in from here inside. The straw will go in from here inside, go to the patient, and then put the glass down here, and he can actually sip it from there. With this, the PEEP will not move. This is how you would probably use to feed your patients or make your patients drink. So this is the entire setting when it comes to setting the ventilator. But at the same time, there are a few more settings that I would like to show here. So what I would like to do is always keep the TI max to 1.5 seconds. This will assure that there is no delayed cycling. It is important to keep this as 1.5 seconds. Otherwise, there can be a chance of delayed cycling. It is very important to keep the ramp as much high as possible. So here the ramp is as much high as possible. It's 200 milliseconds. So keep the ramp to the maximum. Okay. And as I told you, the expiratory time sensitivity, the PEEP has to be at 10, and the ETS, it is always better to keep it at 25% and go as it goes further. As it goes further, we can see what to do, but the ETS you start at 25%. So this would be the starting settings when it comes to using this with the ventilator. Just pause. Setting when it comes to using the invasive ventilator. Now what I'm going to use is, I'm going to try to use this with the high flow nasal cannula. Now with the high flow nasal cannula or the humidified circuit. So let me first switch this off. Let's switch this off first. I'll hold this for you. Switch it off. Let's switch this off. So we're switching this off as of now, and we're now going to connect this to the circuit, which is a high flow circuit. So let's look. I'm taking out the ventilator circuit from here. I'm just taking it out. It's not required anymore. And I'm going to connect the regular high flow circuit to this. We should know this. Let's take it out. So taking out the entire ventilator circuit, and I'm going to use the high flow. You may wish to use any high flow that you have in your hospital, but we'll just see how the settings look like. Okay, so there we connect the ventilator. We connect the high flow circuit here. So this is the Hamilton H900, where we have now connected the high flow circuit over here. But here you must remember that this is only flow, this is not pressure. We want to now give pressure also, and for that we will need a PEEP valve. So this is a PEEP valve, an external PEEP valve that we have over here. This is a PEEP valve which shows 5, 10, 15, 20. It has got the PEEP that is over here. And what I will do now here is, we will have to remove one of the sides. So we've removed one of the sides and attached the PEEP valve over there. We've attached the PEEP valve over there, and as I said, the PEEP has to be dialed at 10. So let's dial the PEEP at 10 over there. Let's dial the PEEP at 10. So we dial the PEEP at 10, leave it over there, and what we do is we attach one side of the circuit to the high flow. So here we have actually so here what we have done is, we have anyways stopped one port. One is attached to the high flow, and that is the PEEP. Now in this, what you must understand is, just like what we talked about, that this has to remain inflated, and for that to remain inflated, we have to go to the high flow settings over here and keep it upwards of 30. Now I go to the high flow, confirm, and we are going to have flow rate of 30. So we need to keep it at least 30 liters per minute over here. So when I confirm that 30 liters per minute, when we start the high flow therapy, this is what we would see. You would see this, that it is slowly and steadily expanding. It's expanding, it's slowly and steadily expanding, and 30 is the minimum you'd want to keep, otherwise this would collapse. Can you just hold this, because we don't have the stirrups, we are just holding it. Okay, now if I were to make it 20, you will notice that it will start collapsing. So it starts collapsing over here right away. See that? It starts collapsing. So we don't want it to collapse, please hold it. We will increase it to 30 or 40 minimum. So I'm taking it to 40 as of now. and starting the therapy. So it's at 40, it started therapy, and this is where my PEEP lies. So I can increase my PEEP, however. So this is helmet CPAP, but used with a high flow. it is not advisable to use CPAP mode with the NIV mode over here with the helmet. It is not advisable to do that per se, because what will go in will come out. We need to use a high flow. If we just use CPAP on this particular machine, there's a very high possibility that patient will have CO2 retention. So we can't use just conventional CPAP. We will need to use high flow with PEEP. That means you need two levels of pressure. You can't just have one level of pressure over there, because of the fact that these patients may then accumulate carbon dioxide. Similarly to what we described later on, we would use the EtCO2 to be placed over there. It could be side stream, it could be mainstream. You can just place it over there. And similarly, if there is an increase in the carbon dioxide by more than 5 on your capnometry, you can actually put oxygen from here and then wash out that carbon dioxide that's coming in over here. You could put a flow of gas or oxygen, whatever you want from here, at 8 to 10 liters and let it wash out the carbon dioxide and then follow up the ABG. This device will allow the person to see all across. He doesn't need, there is no obstruction from anywhere and no creation of any pressure, so any matter. This person can also slide down on his prone, if he wants to be prone ventilated, he can be lied down on prone ventilation, and this will work as well as any other device, and in fact better than the other devices. So this completes everything about high flow, the helmet CPAP. Helmet interface when using it for NIV. Thank you very much.